Thank you all for coming. My name is Chris Alvarado. For those of you who don't know me, I'm a thoracic surgeon. Just started here at Midstate back in April, so I've been here almost 6 months now. And what I wanted to talk to you about today is a new technology that we're starting to see used not only here at Midstate, but really across the country in greater and greater numbers. It's a very promising technology, but before I get to the meat of the talk and tell you about navigational bronchoscopy per se, I want to take a 10-15 minutes or so to kind of put it in context as to why I think it's really going to be a very important addition to the way we treat lung cancer in particular. And so some of these slides may be a review for those of you who were here 2 weeks ago and heard Dr. Hemden's excellent presentation on lung screening. But I think that is a very important thing to go over so that we understand exactly what type of an advance and what type of capability this new technology is going to give us. So I think it's important to take a little bit of an overview and stand back a second. One of the ways I like to think about lung cancer and how it's evolving is very similar in a lot of ways to the way breast cancer was being treated back in the 70s. I remember when I was a boy in grammar school at the time, my mom and her friends were very worried about this. This was something that was really striking at people and making them very afraid. Everybody had a story of a friend of theirs who got sick very early on, had a young family and things. And one of the key things that helped us fight against breast cancer and make it the disease process that we know today, which is mostly for the most part very treatable and very curable, is that we discovered a way to detect it at an early stage using mammograms. And I remember listening to First Lady Betty Ford at the time talking about how important it was to go out and get annual mammograms and taking some of the stigma away from talking about breast cancer in public. And in many ways, that's where we are now, I think, in lung cancer. And part of what we're all very excited about, as Dr. Hemden talked about and Dr. Carroll talked about, is this new lung screening program that we're starting here. So I'll talk in a second about how navigational bronchoscopy kind of dovetails with that. But basically, if we think of CT scanning as a lung mammogram, if you will, navigational bronchoscopy gives us a way to handle and differentiate all of those nodules that are going to come up and all those early cancers into firstly differentiating them from non-cancers and figuring out which ones really are cancers and which ones aren't, and giving us a way to treat them in a more manageable way. So, if we remember back in pharmacology, we all learned about additive versus synergistic, and I think this is one of those circumstances where these two technologies hopefully can be synergistic, where 1 and 1 doesn't just equal 2, but 1 and 1 can equal 4 or even 10. And that synergism can come into play when we think about there's a very large population at risk that we'll start to screen. We're going to find more and more nodules and by inference early cancers. As I said before, we need to discriminate between what are cancers and not cancers and be able to treat them in a more minimally invasive way, in a way that get people out of the hospital more quickly. So a couple of quick slides to review the presentation from a couple of weeks back on lung screening. I always find it shocking to realize that lung cancer is not only the #1 cancer killer in the country, but actually kills more patients every year than breast cancer, prostate cancer, and colon cancer combined. So it really is a tremendous societal issue. This slide here, I think, even if you can't read the letters because they're so small, you see this huge difference between this line of lung cancer versus all the other cancers. And we do see how it's been coming down, and most of that is because of success at getting people to stop smoking. But the fact remains that most people who come down with lung cancer nowadays are former smokers. So just getting people to stop smoking is not going to address the problem. Much as with breast cancer, getting a way to diagnose these cancers at an early stage will make a big difference. We can see how breast cancer is now an 88% 5-year survival. Lung cancer is 15%. Now there's a little bit of an inherent difference in the inherent aggressiveness of the tumors, but nevertheless that's a goal that we can shoot for. We know that stage 1 lung cancers that are resected probably have a 70 to 75, maybe even 80% survival right now. So if we can diagnose more people in an early stage, we're going to do better. And if you look at those mortality rates, another slide that Dr. Hemden showed a couple of weeks back, if you notice all the other, or the next 3 most common cancers, all have relatively accepted screening mechanisms for them. And so now we're getting to a point where we're going to be able to use low-dose chest CTs to be able to do that, and that was essentially proven, really beyond any statistical doubt, in the landmark study published in the New England Journal a couple of summers back. These are the 2 risk groups. For interest of time, I'll go through these, or I won't dwell on these, but needless to say, it's basically people between 50 and 74 with a long history of smoking. The promise, and this has been borne out recently by some data presented by the Leahy Clinic. Leahy Clinic was an early adopter of lung screening and has now been screening people for about 2 years, and they have seen this promise actualized. That is to say that most of the cancers they see now are in early stage. So as opposed to 2/3 of cancers presenting in late stage, at the Leahy Clinic they now see as a result of lung screening that 2/3 of cancers are presenting in an early stage and much more curable. And lastly, this is my favorite slide because I think we all talk about cost effectiveness now and the ways that we can use money effectively. And this was an excellent study done by a group of healthcare economists in Chicago, published in a very well-known journal in healthcare economics called Health Affairs. They basically looked in normalized dollars at how much different technologies for screening would cost to save a quality life year. And found that lung cancer screening was very, very competitive, if not better, than the other 3 main acknowledged screening mechanisms right now: colonoscopy, mammography, and in this case pap smear for cervical cancer. You can see that even in the most liberal estimation, that's still of cost in terms of how much it would cost, it still argues very favorably with the other acknowledged screening mechanisms. These have been endorsed. Recently the Health Preventative Task Force gave a great recommendation for it. We're hoping that Medicare will start to approve that in January. And just to give you an idea of the strength of the recommendation, particularly by the NCCN, they gave it a Category 1, which is actually a higher recommendation than for mammography and for colonoscopy. Based upon high-level evidence, there's uniform consensus that the intervention is appropriate. As I said, payers are starting to do that, and in this day and age, it's a very important consideration. So if we identify a nodule, what are the mechanisms and the modalities we have now to address what's going on in that nodule? So if we look at it from least invasive to most invasive, and I think that it's important to understand that most people who have an abnormality on a lung screening study are going to fall into this group here, watchful waiting. Basically having another radiographic imaging study, but maybe at a quicker interval than otherwise would be called for. We still do bronchoscopies. We call them, in this slide I call it conventional blind bronchoscopy to differentiate from navigational bronchoscopy. There are certainly more invasive ways of doing that, and I think CT-guided needle biopsy is a very good technology. One thing I'll draw your attention to as the talk goes on is that that's not a complication-free technique. It's very good for getting good amounts of tissue, but there's a significant complication rate that goes along with it. So the numbers are about 150,000 people are going to fall into this category of solitary pulmonary nodules. CT-guided biopsies are right now the most commonly used technique, but based on a number of studies, pneumothorax is anywhere between 15 and 42% complication rate. Pneumothorax requiring a chest tube, anywhere between 4 and 17%. And bleeding complications are not unheard of. Certainly not very high, but anywhere between 5 and 10%. the flip side is that it's a very good technique for getting a good amount of tissue. So their sensitivity rate is high, although as with any biopsy procedure, the chance of false negative is also pretty high. So in the Annals of Internal Medicine a couple of years ago, Dr. Weiner, I think, made an excellent comment about how several thousand people in the United States experience complications from CT-guided biopsies, and that number will no doubt increase as we find more and more nodules. So the idea is, how do we approach these in a more minimally invasive way? And in fact, the people who developed navigational bronchoscopy basically used the technology that I'll talk about and adapted it from technology used for fighter jets to targets with missiles, and adopted it so that we can actually target lesions in the lung. And I think you'll see it's a pretty impressive technology. So bronchoscopy is performed about 500,000 times a year. Unfortunately, we're limited with conventional bronchoscopy with what we can actually see at the end of the scope. And so that limits our reach, if you will, to really the central airways, because you can't take a bronchoscope in and of itself and drive it all the way out to the periphery where maybe a nodule might be in the upper reaches of the upper lobes or down in the lower reaches of the lower lobe. We're pretty much confined to this box in the center. And as a result, it's pretty clear that diagnostic yields for peripheral lesions are, really not that good. I want to start off by reading for you a consensus statement from the American College of Chest Physicians about navigational bronchoscopy. In a recent issue in Chest, I think in either March or April, they devoted the entire supplement to the issue to current rationales for treating lung cancer. And in the section about diagnosis, they made this fairly declarative sentence. In patients with peripheral lung lesions difficult to reach with conventional bronchoscopy, so that's to say those outside the fairly central airways, electromagnetic navigation guidance is recommended if the equipment and the expertise are available. And that's a grade 1C recommendation. You recall from the table that I showed you about grades of recommendation for lung screening, the grade 1 is essentially a consensus of the NCCN. It's a very strong recommendation. If electromagnetic navigation is not available, TTNA is certainly recommended, because that is an excellent technique. So what are the things that we can do? And when you ever see Superdimension, Superdimension is the company that developed this technique. It's right now, much like the robot, which we use here, which is developed by Intuitive, they're a monopoly. They're the only company that pretty much makes this right now. So anytime you see Superdimension, that's pretty much synonymous with navigational bronchoscopy. So there are 4 different things that we can try to do. For one, we can go out and biopsy lesions. For 2, we can use it to stage lymph nodes, either at the hilum or along the trachea. We can use it to place markers to guide radiation treatment down the road, so that can be seen very easily. And I'll show you a slide later on about how we can localize lesions intraoperatively, so that if we start approaching these smaller and smaller lesions, one of the things that we as surgeons lose as we use either thoracoscopes or robotic-assisted techniques is we lose the ability to feel the lung with our fingers. And so we have to figure out a way to replace that haptic feedback, if you will, that tactile sensation, with something that will guide us to where to appropriately cut. And navigational bronchoscope is an excellent technique for either putting a marker or a dye or something to say to us, well, that's where the lesion is. So the process starts way before you actually get to the operating room. And I think one thing to point out is it even starts with the CT scan. The CT scan, we generally have to have a CT scan with thin cuts, 0.625 millimeter cuts. Most CT scans are done that way already, but they're a tremendous amount of information, so it's not archived for a long, long time. So sometimes we actually have to repeat a CAT scan in order to get those thin cuts. And once we get the CAT scan with all the information we need, we, in our office, using proprietary software, we can load that onto a special computer. I have one in my office. It's the only thing it does is does this sort of planning. And I'll go through in a second what the planning is, but it'll generate a 3D bronchogram and highlight the best pathway to actually get out to the lesion. And then after you've planned it and after you've put all those things in place, then you actually go and do the procedure in the OR, and I'll go over that as well. So this is the type of image that you would see on your laptop. You can see where the lesion is here in a bunch of different views, either axial or coronal or sagittal. And based on the information in the CT scan, a 3D bronchogram is generated, which will show you many, many generations of the different subsegments, not just the central ones, but the ones way out there, because those are the ones that we're going to utilize to get out to lesions that are peripheral. And once you've actually run everything through the software, you get this virtual bronchogram where a pathway will then be highlighted for how to get out to the lesion. So sometimes the best way to show these things is with a video, and hopefully this is going to work, but I think it should. So the software is actually very sensitive. It'll tell you if the CAT scan you've loaded does have enough information. It'll rate it in terms of stars, 1 to 5 stars. And then it'll allow you to scroll through the lung, finding a lesion like, for instance, this one here. So if that's your target lesion, out peripheral in the upper lobe in this case, then you can size it, to make sure that you have as much of the lesion represented as you want. And it'll show it to you in a 3-dimensional format, so you're sure about what the bronchial tree looks like going out there.